All right, I think I'll go ahead and get us started for today. Welcome to our annual Fall Implementation Science Seminar Series. My name is Dr. Alethea Gerosiers. I'm an associate professor in the Department of Psychiatry and Human Behavior at Brown University, and I'll be hosting the Fall Seminar Series. This is now the 8th year of our Bridge program's Implementation Science programming, and we are truly thrilled to bring these seminars to our Providence and Rhode Island community of implementation scientists, as well as those of you who are joining us from other regions. We are grateful for the partnership of the Advanced Rhode Island Clinical and Translational Research, or ADVANCED-CTR, for supporting the technology, logistics, and marketing of these seminars. And we also recognize our partnership with the Brown Alcohol Research Center on HIV for their support. And now it's my pleasure to introduce our speaker for today, Dr. Carly Goldstein. Dr. Goldstein is an assistant professor of psychiatry and human behavior at the Brown Alpert Medical School and the Weight Control and Diabetes Research Center of the Miriam Hospital. Her research focuses on developing and improving mHealth interventions and prevention programs for obesity, cardiovascular disease, and medically complex patients using novel technology. Most of her work uses optimization methods like the Multiphase Optimization Strategy, or MOST, and sequential multiple assignment randomized trials, or SMART. She collaborates with patients and healthcare providers to develop and disseminate interventions through participatory methods and science communication. The title of her presentation today is Intervention Optimization from Effectiveness Through Implementation Success. As a reminder, you can put your questions in the chat function throughout the seminar, and we'll save time for Q&A at the end. And now, thank you so much, Dr. Goldstein, for joining us today, and I will turn it over to you now.
Thank you so much for inviting me. I'm so pleased to be here talking about, honestly, the marriage of two of my absolute favorite subjects, optimization and implementation science. I wanted to thank the hosts today for inviting me. Also, a shout out to Advanced CTR. My optimization work in my program of research was kicked off by one of the first mentored research awards. So I'm very grateful for, the local resources for hosting and for, enabling the trajectory of this work. So thank you. In the words of my good friend, Dr. LaPrincess Brewer, I have no disclosures, but I'm always looking for some. My research funding currently comes from the National Institutes of Health. So let's start off by kind of talking about our current black box approach to intervention science. What most of us think is more is often better. So we assemble these multi-component interventions that might include phone coaching, self-monitoring, feedback, a variety of other interventions. And we package them together into one biobehavioral intervention, and we conduct our randomized controlled trials and we get our results. What can really easily happen, though, is that you get to the end of your research study and you don't always find clinically or statistically significant results. And the problem is that at that point, you have pretty limited options for disentangling what went well, what kind of went wrong. And part of that is because of this combination of the components. So you don't know in the treatment package approach how the components are working together. So you're often left with more questions than answers. You don't know if maybe one component actually worked really well, but another component was kind of limiting the effects of that first component. You don't know if the dose of the components was the right fit. Maybe if you had just stepped up the dose of one of the components, the entire package would have worked together. But the problem with a randomized controlled trial is, when we are using it to determine a treatment package, we don't really know what's going on in the black box. And many of us in intervention science have kind of grown to accept that. So a randomized controlled trial that finds a significant effect can't tell us what intervention components are contributing to the significant effect and whether, one is impacting another. We also don't know if including a component justifies the financial or time costs to both the research team, to payers, and even to participants themselves. And it certainly doesn't tell us anything about like scalability, effectiveness in some cases, or like the economy of the intervention. And a randomized control trial that finds a non-significant effect can't tell us if any of the components are working well together and are worth keeping, or if, again, one had that negative effect offsetting the other. This happened to me when I was running my thesis in graduate school. I conducted a randomized controlled trial of two medication reminder systems with and without reminders. It felt like a slam dunk intervention at the time. Like, obviously, the more polished iPhone app with the reminders was going to work. And in the end, it was kind of all a wash, and we didn't really know what exactly to do or why. And so really the problem in intervention science that I would say is really paramount is that many researchers are trying to ask important questions that our randomized controlled trials just weren't built to answer. And that's where intervention optimization comes in. So it borrows from governing principles from psychology, engineering, and public health. And it's a process of creating and refining biobehavioral interventions. What I love about it is that it's intended to move science forward both fast and phasically. And so once I came to Brown and I was doing more obesity related work, I found it so interesting that, if you read a study at, say, your institution, you find that self-monitoring and phone coaching works great. But then you read another study in the same exact population, but conducted at a research institution an hour away, and the same combination didn't work. Optimization approaches are trying to get us away from those sort of pitfalls, where hopefully we're going to be able to build a science base faster and just know more certainly, what's going to work and with what reliability can we count on that. Um, so there are many different ways to approach intervention optimization. My specialty is in the multiphase optimization strategy, or MOST, which is a research paradigm or framework. I'm going to explain more of that in a moment. Um, Many people, when they think of intervention optimization, and more specifically MOST, they think of the full factorial experiment. So it might be where I have four conditions, each offered at two levels. And so if you're thinking about it in terms of the traditional RCT, that works out to like 16 different conditions in a sense. It can be very overwhelming, but also a very exciting way to test things. Really, though, the multi-phase optimization strategy is, again, it's a framework. So it's a preparation phase to begin, and then an optimization phase followed by, once we have a more solid treatment package that we've created, that's when we test it in an RCT. And so the key thing to know if you're interested in MOST is that that second phase optimization can use any resource efficient design. So it can be the full factorial experiment, but it can also be a sequential multiple assignment randomized trial. It can be a micro randomized trial. It can be a system identification experiment, also known as system ID. But again, it's just any resource efficient design for the process of selecting, decision rules or what should be in the optimized intervention. Um, I think of it a lot as kind of like a process similar to baking. So I remember baking with my friends when I was in high school, and our cookies coming out like totally flat and not being sure what exactly went wrong, and being able to research, oh, if you accidentally leave out an egg or the baking soda, this is going to be the effect. And so there's this kind of like phasic approach where we know, like, okay, definitively this is what happens when you accidentally do a tablespoon instead of a teaspoon of one of these baking ingredients. Most and intervention optimization to me is answering these questions of, well, what if I leave out half the flour? What if I add an extra egg or double the baking soda? Um, it's just similar to, well, what if we offer coaching once a week versus twice a week? What about if it's in person or virtual, group or individual? All of these different questions around like dose and format that we might want to answer. Um, so each research team, when they're using the most framework, will specify an optimization criteria, which blends the need of real world impact of that statistical and clinical significance. So again, I was doing medication adherence related work, and we devised an intervention that was able to produce whatever percent improvement in medication adherence, and I was thrilled, and then kind of got hit with the question of, well, is this clinically meaningful? And if it is, are the costs of delivering the intervention sufficient to warrant actually, paying for it and delivering it and devoting staff and patient time to it? And so rather than kind of getting hit with those questions down the road, intervention optimization, and in particular most, allows us to think about those things up front. And I know for sure that I'm preaching to the choir here, given that most of this audience is going to be implementation science researchers. You guys are always thinking of these things from the beginning, because is it really worth, devoting a lot of time and resources to delivering or researching these evidence-based practices if we kind of know from the start that there's no way in heck that these are ever going to fly in the settings that we want them to be delivered in. And so for me, intervention optimization is just a really exciting natural marriage of these priorities that I think are really aligned. And yeah, there's just endless possibilities here. So, most I mentioned is a research framework that prioritizes resource efficiency, and it allows researchers to thoughtfully blend statistical and clinical significance. And the other thing that really appealed to me is that it encourages repeated optimization. So most of my work is in digital health. Um, can you imagine if you downloaded an app from the App Store and then that was it? You never downloaded an update ever again. You didn't update your iPhone. I'm not still working off of my iPhone 3. Thankfully, all of the apps that I love to use get updated pretty regularly. A lot of us are doing digital health work, and this priority in most of repeated optimization we see across our different areas, and so it's just a really kind of natural framework for thinking about research. um, so this framework originated from engineering principles, and it was originated by one of my mentors, Dr. Linda Collins, who's now at NYU. And there are three phases of most. I apologize for those for whom this is, repeated information. Excuse me, and I thank her for permission to use this graphic. So the preparation phase of most is where you form the basis of your theoretical model via a combination of things. So it's not just pilot studies. It may not just be a literature review. It's incorporating secondary analysis from data that you've already collected or from other teams. It's where you might be pilot testing individual components and determining the right levels. And by levels, I mean, okay, we're going to do, self-monitoring and feedback. Do people need feedback every day? Do they need it every week? Or do they need it every month? And maybe we do some pilot testing to determine which of those two time frames we want to offer feedback on. And then again, critically, this is where we identify and define a meaningful optimization criterion. So that, for example, might be like the most effective intervention that you can deliver, that doesn't have any dead weight in it, that costs less than $300 a person, and takes fewer than 4 hours across patient and provider time. And a component is any part of the intervention that can be separated out for study. In the optimization phase, this is where we conduct the component selection experiment. This is where you collect data to determine the optimized intervention that meets the intervention criterion via an efficient randomized experiment. So this is what most people are thinking of when they're thinking of most. The purpose is, or sorry, most people typically use a full factorial, like I mentioned, or you might use SMART. In here, we say that significance is determined by the main effect criterion. Excuse me. But the main effect criterion will vary depending on how many levels of the component that you're testing. So just as a word to the wise, it's better to add more components in terms of the resources that requires rather than to actually add more levels. But obviously both can be done. There are also fractional factorial experiments, which are a bit more complicated. I won't go into those today, but again, there's just multiple ways to get at this optimization process. This is again where we're going to make determinations of what to do next based on the effect size estimates in the component selection experiment. And so at the end of the phase, researchers have determined the optimized intervention, including the appropriate levels of the components. And so if the effect size estimates in the component selection experiment suggest that the optimized intervention will have a sufficiently large effect, then it's justified to move on to the next phase, which is the randomized control trial or the evaluation phase. But if the effect sizes are really small, this is again where that repeated optimization can take place, and it might be better off resource-wise to go back actually to the preparation phase at this point. Or you might want to go back to the levels that you've selected. Maybe that's where the issue lies. But again, you're just kind of avoiding that experience of getting all the way to the very end of your evaluation phase with uncertainty about what to do. And so once you have your optimized intervention package, you're going to do a randomized controlled trial of the optimized intervention that meets the previously defined optimization criterion compared to whatever a meaningful control would be. And the goal is obviously to determine if the optimized treatment is superior to control. And this is what most of us are already familiar with, right? So this is where we then decide if it's time to release the intervention. And it might be, and we might actually still want to even return to the preparation phase once the intervention is released, or we might decide that we need to go back there before releasing something. So, a biobehavioral intervention is a program that typically aims to improve and maintain health and our well-being. It usually consists of multiple components to form the intervention conditions and the control condition. And a component itself is part of the intervention, like I said, that can be separated out for study. It could be part of the intervention content, something to improve adherence or engagement, or it can be aimed at improving fidelity and treatment delivery. It can also be a combination of any of these things, which is one of the reasons why, as an implementation scientist, this framework really interests me because I love the idea of, thinking about these like hybrid designs and just how can we be lending a focus towards the implementation success as well as the effectiveness of the intervention. So for anyone who is interested in most especially or optimization generally, I hope you already have copies of these. These are kind of like the most Bibles, if you will. If you are affiliated with Brown, we actually have free access to these through the library. So go ahead and grab that PDF off the library website. But yeah, these are just like your home base basically for all of your most questions and interest. So I'm going to give you an example of this work in practice. So I conducted a fully automated physical activity, or sorry, a fully automated digital health intervention for adults finishing cardiac rehab using a full factorial experiment aligned with the multiphase optimization strategy paradigm. And so you can see kind of what this has looked like in my work, for example. So, cardiac rehab is the gold standard treatment for adults to receive after they experience a cardiovascular event. It's a 4 to 12 week science-backed program that combines supervised prescriptive exercise with psychoeducation and access to allied health like pharmacists, behavioral therapists, and nutrition counseling. So this outpatient program um, rightfully focuses on heart health, but in my work, I found that many patients were coming in explicitly stating weight loss as a goal. Um, but weight loss is not actually a focus on cardiac rehab. However, weight loss boosts cardiac rehab effects for patients with a higher starting body weight, independent of the other improvements that they hopefully achieve. So cardiac rehab patients typically only lose about 2% of their body weight, and that's in the top performing programs. Um, and so many of them end up failing to meet this secondary health goal of weight loss, and that can, in fact, discourage people from continuing to adhere to the behaviors that are healthful and improving their heart health, like eating well and exercising after rehab, despite making these really clinically significant improvements in their heart health. Um, and so our previous work showed that patients really wanted low burden digital health interventions for improving their health behaviors and weight loss after cardiac rehab. Um, they wanted these tools to kind of come with them once the program ended. Um, but there's a ton of research suggesting all these different tools that people could use, but not really a lot of definitive work on what exactly is the best fit for this niche population. Um, this population also contends with extensive burden, and so just overwhelming them with different options is definitely not the way to go. Um, the cardiac rehab providers we knew through my work, they required and preferred digital tools to be delivered outside of cardiac rehab hours because the cardiac rehab programs are accredited and they are just like really full. So they didn't really have a lot of time for extra intervention delivery. And so most was just this great paradigm to use to quickly identify these components without overburdening the patients and the providers. Um, so this was a 2 to the 4 factorial design that was offered where we gave everyone an online weight loss program and then additional components to determine which offered an additional clinically significant weight loss above and beyond what we expected from the base program, which was about 5%. So we had 198 participants who were an average of about 60 years old, who were referred before they finished cardiac rehab. They were all given that core weight loss program, and then they were randomized to receive anywhere from none to 4 additional components. So a physical activity program with a Fitbit, a wrist-worn bike counter and a bike goal, an online virtual reality game, and group virtual meetings. So we conducted analyses to examine weight change, specified as percent weight loss of initial body weight um, at 6 months following the intent to treat principle. And at the time, we had 2 people who had not completed their last assessment. We used effect coding controlled for baseline body weight and included age, sex, identification with a racial or ethnic minority group, marital status, and educational attainment as covariates. We found that most participants lost about 4.65% of their body weight at 3 months and 8.13% at 6 months, so far outperforming what we typically see from cardiac rehab. Um, we found that the physical activity intervention component group lost more weight than those who didn't receive that component at 6 months, thereby exceeding the optimization criterion for inclusion in the final treatment package. However, there weren't weight loss differences observed in people who received the other components. And there was no significant effect of the intervention on weight change from 3 to 6 months, suggesting that additional support for moderate to vigorous physical activity after cardiac rehab is particularly beneficial for weight loss when combined with an evidence-based online behavioral weight loss program. Which is like a really important thing to note. Like many people are not accessing evidence-based treatments when they are seeking, self-driven support for weight loss after rehab. And so, provided we can connect people with those existing resources, something like additional physical activity support might especially benefit them. So we're in the process of conducting additional analyses on the complete data set now that all patients have finished their assessments. And we're also very excited to conduct additional analyses on additional mediators of the intervention effects. So seeing like delivering one intervention component drastically affect the performance of another. That's again where most is just going to be so helpful, and this framework is going to be hopefully helpful in us figuring out what to do next. And then ultimately, we'll conduct a randomized controlled trial of the optimized treatment package compared to usual care. And we're going to look to further optimize that treatment package as well, to increase the magnitude of weight loss for those who need it and to maximize cardiovascular health. So this was the first study using most in cardiac rehab. I will say the results aren't published yet, so stay tuned once those are accepted. But we again found that physical activity was the best bolster to weight loss. And out of rehab physical activity support that maximizes feasibility and meets patients' and providers' needs was our best bet. And we also plan to try to look at if participants with certain like social behavioral phenotypes display differential benefits from specific intervention components. So that will be a really exciting avenue as well. I want to turn now to another design that is often used in intervention optimization, which is called sequential multiple assignment randomized trials. You might know them as SMARTs. So this design also really appeals to me because, when we are delivering an intervention in the course of clinical care or in terms of research, you see those people right away who are not responding. And on our typical research protocols, that's it. That's just what their trajectory is going to be, right? Like maybe there's going to be something in the intervention content that they're going to find helpful, but we're not usually getting more involved beyond that. And that is a complete disconnect with how we operate clinically. So, like, in what world would a clinician give somebody one intervention and be like, oh, it's not working, but that's what we decided. So see you in 3 months. Like, no, that doesn't work at all. Um, so this is a really exciting opportunity to, applying best principles of research to actually like re-randomize people and to see if we can meet them and get them to respond adequately. I also really empathize with non-responders, like, whether it's in your personal life or whatever. Can you imagine like starting a treatment and then it not working? Like you would feel so abandoned, I think, if the research team you were working with or your clinician just didn't do anything at that point. So, between the alignment with clinical practice and really kind of thinking about the experience of research from the participant perspective, I think that smarts are a really unique and exciting opportunity. So these provide data to develop adaptive interventions where participants are randomly assigned to different treatments at different stages. You can have several adaptive interventions embedded within each SMART, and it can allow for testing of the tailoring value variables and decision rules. It can involve tech, but it doesn't have to. Here is kind of a classic example of a smart design. One piece of advice though, if you want more than two randomization points, you're probably going to need some really big effects that you're looking for, or that you expect to see, and probably a really large sample size. So before you get too excited with thinking about like 12 randomizations in a single design, just keep in mind that power could be an issue if you wanted to do that. So in this study, we can see that patients were first randomized to receive naltrexone and medical management with either lenient or stringent criteria for classifying non-response. And then interestingly, rather than waiting until a specified time, like your 8-week assessment, once they met non-response criteria, they that stuck and they were re-randomized. On the other hand, if they responded consecutively for 8 weeks, then they were at that point labeled a responder. One of the things that I love about SMARTS is that you can take the folks who are responding and re-randomize them to receive a stepped down intervention, which oftentimes mirrors what we actually need to do, from an implementation perspective. Or for folks who are not responding, we can randomize them to receive something stepped up. So, ooh, wrong way. So that's what we're doing in my recently funded R01 in the Empower Me study. We're taking folks who completed cardiac rehab and who need help with their maintenance regarding medication adherence, physical activity, and weight management. They're starting being randomized to one of two low intensity interventions. If they do respond, we're not messing with what's not broken, so they just continue in that case with their intervention. But for the non-responders, they're going to be re-randomized to receive one of two bumped up in intensity interventions. Um, and so we're very excited to be recruiting beginning in the new year. And I'm happy to talk in the questions about kind of like what it's like to talk to patients about these designs. But it's typically really exciting. Um, at the beginning of the talk, I posed like, well, what's wrong with what we're doing now? And I said that many of us we're asking important questions that our RCTs weren't built to answer. But I would say that also explicitly extends to implementation research questions as well. And so it's time to answer some of our implementation research questions by looking to these designs and not solely relying on, just an RCT. Um, and it's exciting that we can really ask implementation science questions using optimization methods. So for everyone attending, these are like the two articles that you need to read. If this is an area of interest for you, these are like your home base articles for the marriage of optimization and implementation science. Um, and so one of the things that we can do is we can actually study the optimization of an intervention's implementation. And this is probably what most people are thinking of when they imagine combining these two research areas. So if the intervention's implementation strategy can be broken down into components, you could determine which components are pulling their weight and via what mechanisms. Let me tell you, this idea is particularly appealing to working with clinical staff because they love to know that you're not going to be wasting their time or resources asking them to, devote effort to implementation strategies that are just not going to work in that setting. It would require the implementation strategy to be distinct from the core intervention. So, like if you're trying to implement a self-guided CBT for depression in primary care, you would need to then additionally be using various implementation strategies like champions, financial incentives for patients or providers, and medical assistant training. And those have to be able to be disentangled. This is also a beautiful opportunity for hybrid implementation effectiveness designs, which I know many of you are already familiar with. So this article is one of my favorite examples of what I've been talking about. This is a great example of a clustered SMART in which they aim to use the least costly methods for deploying a CBT-based program in schools. Their interventions map onto specific implementation barriers and they vary in cost, with the idea being that some will work fine with the cheapest strategy and others might need a more costly strategy. And so after 8 weeks, non-responding schools, which is measured as insufficient delivery of the intervention. So it's not that the intervention is not working, it's that like implementation wise, they're encountering barriers. Those schools would receive additional support for implementation. And I just love this study because it just so perfectly follows how I think about like the real world application of trying to facilitate like uptake of an evidence-based intervention in a limited resource setting. And all of us pretty much are operating in settings that are limited in resources in some way, be it time or otherwise. Um, So, like, of course, I'm going to try the cheapest intervention or least invasive or least time intensive intervention first before I devote more to additional resources. And that's just what you have to do when you're trying to implement a program in literally 100 places across more than 200 staff members. And so this program I think is, or this study is just like so practical in how this would actually work in real life, if you will. Um, They had two different ways of classifying and categorizing non-response, which I found really interesting. So it was either the school professionals delivering too few intervention components to a very restricted number of students, or just even professionals reporting numerous barriers to actually implementing the intervention. Um, that I think is so important because practically it saves a lot of staff time and burden, prevents staff from spinning their wheels. Um, and it mirrors just what I found when we were doing a hybrid implementation effectiveness design. Um, so there was like one case where we were doing this study and we were working with nurse care managers, and some of them would come in right away being like, I'm not going to be able to offer this weight loss program in this clinic. I know that the doctor does not have like buy-in on this and they don't really value what I say. And so there were cases where I would actually go in and meet with the doctor, and that was kind of like the thing that really helped. In other cases, they were like, the doctor doesn't know you. Like they know me, they trust me, like let me present it to them. And that was the thing that worked. So it just allows for so much tailoring to the setting that I think is really exciting. And it doesn't require your participants or your sites to fail first before you help them. You can be really thoughtful in your responder criteria to avoid that, which I think is ethical and just really important. So we can also design interventions that are immediately both effective and scalable. In the preparation phase of most, we can specify the optimization objective, which clarifies how effectiveness will be balanced. And we can design interventions that will be feasible. Like we want to choose the most effective intervention that costs less than $100 per person and takes under 3 hours to deliver. The researcher can also conduct pilot trials to determine or improve acceptability and feasibility of those intervention components. And then in the optimization phase per most, this is where we would utilize any resource efficient design. And it could be really appealing to build like a stepped care implementation approach. And it's where we'll determine how the components perform and provide information on which components to use in the RCT. And at that point, um, this is where we can consider only implementable interventions that are efficacious under the implementation settings constraints. So it's not like a let's think of any old idea that can work. It's like no, let's be realistic about what will actually work in the settings that we're working with and with the partners that we're working with. So, following the evaluation phase, even a return to the drawing board isn't a full restart from square one because the researchers are going to have information on what didn't work and why, which again is just like the the chef's kiss of the most process. Um, and then lastly, we can adapt interventions to local context. Um, we all know that heterogeneity in local settings can necessitate similar but different optimization objectives. And so changing constraints in local settings may necessitate iterative optimization like workflows, volumes, staffing changes. Some of these we know ahead of time about our context before we start a study. Some of them kind of come up as you go, and it's nice to be able to be flexible and kind of build out what we need for each setting to be successful. When I'm talking to my patients in my R01 about exercising outside, I'm going to be using national recruitment. And some of those folks are going to be living in cities, some in rural areas. Some will have to deal with especially hot weather in the summers or especially cold weather in the winters. We're going to need to provide information about adjusting to the local context. And if we're working then also with the cardiac rehab staff, we need to make sure that our intervention materials are tailorable to fit where they are. And I think that that's also just an important part about like working with staff and collaborating with them. And that was one of the reasons that I wanted to design some of my studies to use these designs because when I'm conducting a full factorial trial, the way that I do it is I always offer like a core program in addition to the components. And so everyone gets something. And so many people understand from research that you might get randomized to a placebo, and that's really unappealing. In this case, they're kind of not going to be getting a placebo because they're going to be getting this core program that we know is helpful. And so case managers, care providers are enthusiastic to hear that. And it's going to come through when they are working with you on recruitment and they want to help people get into your study. Um, Also, again, it just maps onto like clinical practice that when someone is not responding, like in the case of a smart design, that we would offer them something different. We don't just say like, all right, see you at the end assessment. um, and so I think that this is just a really nice opportunity to work with the people who are in your care settings or in the settings in which you conduct your work. And so a piece of advice would be to kind of talk to them about the actual like process of research before you develop your next study. Like, learn, are they okay with referring to studies that have a control group that might be a no intervention or delayed intervention control group. I think that there's just like a lot that you can learn from talking to the providers in these settings before you actually, implement your next trial design. I know I breezed through a lot of that, but I'm really looking forward to having plenty of time for questions. I'd like to thank my collaborators in funding. The two great numbers are my current funding, but also many thanks to the Rhode Island Foundation, Advanced CTR, Star Cobry, and others for past funding. And above all, I'd like to thank my past, present, and future participants and patients, their families, and the providers that they or I worked with to enable this work. So please definitely contact me with any questions, but I'm looking forward to having our conversation now. Thanks.
Thank you so much, Dr. Goldstein. For anyone who was not familiar with most or smart designs, you really did a fantastic job providing some backgrounds to get people's appetites, I think, going there.
Thank
So
you.
we have some questions to get things rolling. One question is, can you discuss some useful ways that cost has been captured during the preparation phase of most?
Yeah, that's a excellent question. Um, you can do, some cost effectiveness information, based on previous studies that you've done or reaching out to other researchers. So, for example, if there's like a staff delivery of an intervention, figuring out what they would be paid at your institution or a range of what they would be paid in the areas where the intervention is going to be delivered, figuring out the number of hours that they're going to need, not just for actually delivering the intervention, but for the, before and after stuff too. Like, are there notes that they need to do afterwards, preparation time, etc. And you know it's just something that you can really build in from the start. And so I recommend that even if you don't want to analyze cost effectiveness in your study, which I would say you should consider doing, just take very careful notes about, like, okay, my interventionist has a master's degree. They said that they spent X amount of time on this per week, and just tracking kind of these different aspects. It's then something that you could go back to later, maybe not for a full paper, but maybe for planning for your next grant or planning out cost effectiveness analyses for your next grant. Um, and it's something too that you could then like work with another research team if they're implementing. excuse me, implementing a similar intervention, but in a different context, you could be evaluating how the costs are going to be different across the context. So that's a fantastic question.
Thanks so much. Another question is, why did you decide to compare the automated online intervention versus text messaging in the SMART trial, given that the online intervention seemed to perform well in your factorial trial?
Oh, that's a great question. Those are actually, I'm sorry for not clarifying. Those are different interventions. I work with a lot of automated online interventions, and the one that we're doing in the SMART trial actually has not been tested in that form yet. So it's an adapted version of a in-person group delivered program that was originated by Doctors Graham Thomas, Steph Goldstein, and Tommy Cho. Um, and we are adapting it for online delivery. On the other hand, the online version that was in the factorial trial was the core program that we've used actually for years and years at the Weight Control Center. It's a really effective program, but it has a kind of more sort of old school approach to weight loss. And, we've learned from patients that they're really looking for something different these days when it comes to their weight loss. So that's the rationale for why we are, changing it up quite a bit. But I apologize for that point of confusion.
Thanks for clarifying that. Kind of relatedly, since we're talking about like patient input and their perspectives, I was wondering if you could go back to something you mentioned related to how you describe or talk to patients about these study designs, because I think that's a really interesting point that whether we're clinicians or researchers thinking about applying some of this and how to really go about that with the patients.
Yeah, thank you. So I was surprised at how much I enjoyed explaining full factorial designs to patients in the context of that award. Um, I would describe to them that our team has done a lot of work for over 10 years now on that core program. We know that it works. And a lot of times we think in terms of when we're trying to make a health behavior change, more is better. But that's not entirely true. Sometimes, yes, like giving us more things to do might make us lose more weight, but it's also a bigger burden, takes more time out of our day. And if I know anything about these patients, it's that they have a lot of demands on their time. And they're usually like, yes, I totally agree. So we'd say, you know, it might be that just giving you this program is enough. And that would be very exciting. It might be that we could give you 4 additional tools to use, and it would be a good amount of your time, but it could be so effective that it might be well worth it. It also might be the case that there's something in between, and maybe giving you 2 or 3 of these different interventions is our best bet. Um, but we don't know that, like, let's say 2 is the best number for you, but maybe someone else needs something different. And being able to use this sort of design will allow us to look at all the different permutations and look at like the average response amongst people who finish cardiac rehab, um, to see which is just going to be our best treatment package. The way I also explain the concept of dead weight to patients when I'm explaining how we've typically done things when I'm describing a most related study is I'll say, let's say you had some medical condition, let's say, goodness forbid, you had cancer, and we wanted to figure out the best treatment for you. And your oncologist prescribed this certain chemo regimen plus standing on your head for an hour a day. And after 6 months of doing that, you found that the tumor was smaller, which is very exciting. However, at that point, you don't technically know how much of it was the chemo versus how much of it was standing on your head for an hour a day. And if we could avoid having you stand on your head for an hour a day or avoid going through, chemo, we would probably prefer that. And so it's really important for us to conduct studies where we can disentangle the effects of these different pieces of the intervention, because we don't want to burden people with like dead weight stuff to do. Um, that usually really resonates with people. And then briefly in regards to smart designs, um, I'll kind of say like we have these two interventions that we think can work possibly really well for you, but like we don't know. We need to test it, and who knows where life will be taking us. So, like a lot of people in cardiac rehab might have rehospitalizations, they can have onset of new health conditions. And so we'll say, maybe as of right now, this seems like enough of an intervention for you, but maybe things are about to get a little more complicated. We want to make sure that we're rising to meet your needs. This sort of program allows us to give you an intervention, take a bit of time for you to get used to it, see if it's working for you. And then if it is, we won't bother you. Or in some cases, we would say, if it is working, we can take some of it away because we think that you can probably do it on your own. It's like removing the training wheels. But in other places, we don't want to leave you in a lurch. And we really appreciate and value the work that you're putting into the study. And if we see that, we're not helping you achieve the goals that you're setting out for, then we want to offer you further support. And so at that point, we would make available additional support to help you get to these goals that align with our program goals. Um, we generally have found that people are very, very open to them. I've actually like conducted qualitative work, just kind of describing these different methods to people and seeing how they felt about it. And all of that messaging was well received in the group that I met with. So I think it is important as part of the preparation phase of most to run this by your particular participant population, and also by the people who you're going to collaborate with for recruitment. Because again, like I mentioned with the case managers, like they don't like the idea of sending their people to like get a placebo or get nothing, like a waitlist control. They like the idea that like everyone gets something. And so that was something that we now factor into the work that we're doing.
Well, that's super helpful. And I think it highlights in some ways how you really also apply participatory research methods and, community engaged methods to be engaging your participants or target population throughout the whole process, or interested parties or stakeholders or whatever words are most appropriate these days.
Yeah.
But I think it's just it's a nice illustration of how that also, the methods you use are so much about thinking about your target population and engaging them throughout the process.
Yeah, absolutely. Thank you.
You're welcome. Yeah. So, okay. So we have a few more questions. One question is about thinking that it can be tricky to disentangle strategies from the intervention. And do you have any thoughts on how to help folks sort this out? So whether something is a strategy or it's an intervention, I think this is about like intervention components, I'm guessing, whether they're strategies or they're an intervention.
Yeah, I'm gonna preface it to say that I might not answer this question very well, but I'm gonna try. Um, a component is anything that you can separate out for study. And so in some cases, these two things are going to be kind of like melded together. Um, I would think about the levels, and if you can control the levels, then it's probably sufficiently a component, meaning that like if you can not give it at all to some people and like give it on full blast or give it like a low versus a high version to other people, then it's like it meets the criteria enough to be considered a component. I'm happy to get additional context for that question though, and try to formulate a better response. I'm not sure if that was helpful at all.
Yeah, well, I think since you have your email here, I would encourage, this is from Dr. Ariana Albanese. I would encourage her to just follow up with you maybe after
Yeah,
that.
that'd be great.
Okay, and then another comment and question. One challenge I face with smart designs is determining the appropriate time to re-randomize based on non-response.
Oh
Say,
yeah.
3 or 4 months post-trial start, have you used most to help determine that optimal re-randomization time point?
Yeah, that's a fantastic question. I would say that it it wasn't particularly sophisticated, but I would say technically I've used most for that in that we did a pretty big like literature deep dive to start to try to figure that out. And a lot of the cardiac rehab work evaluates people about 3 months after they finish rehab. And that's because they actually complete these additional like phone questions because people are oftentimes tracked for up to a year or so or 18 months after they finish rehab. Um, and we kind of knew from this research that 3 months, like you've already lost so many people. So there was like one study where we found in terms of physical activity that by 3 months or so out, people who were achieving like 150 minutes of moderate to vigorous physical activity a week, which is the guideline at the end of rehab, some of them were down to, by accelerometer measurement, 13 minutes of moderate to vigorous physical activity a week. And so that then combined with the qualitative work where we tried to ask people like when would be the right time to receive an intervention? Do you want to receive it during rehab, after rehab, whatever? And we found in particular from a lot of people who worked full-time jobs, they had to adjust their work schedule to go to cardiac rehab, and then they needed some time to kind of get back up and running. And so it was kind of a combination from different sources. Um, just through the preparation phase that we decided on, okay, we're going to reevaluate people after receiving 2 months of intervention because we're kind of trying to get like in the middle of what we know. But you could absolutely use like a more methodical approach to actually determining um, when to actually deliver these or to like reassess response. And that would be really interesting. And for some populations too, I think that that would be like extraordinarily beneficial. What I love about that too is that that like really honors the phasic approach to these designs where like that would be such helpful information for like another research team to apply um in the creation of their smart trial next. So that's a very exciting question.
Great. Maybe we'll see some of that in some future designs and studies.
Yeah, shoot me an email,
Um,
right? We'll write that grant.
So we're almost out of time. We had another question that was just about, how easy or difficult might it be for people to use most for the first time. So I'm kind of wondering if maybe you could share any resources or tips for kind of more information or training or resources to learn more and get more familiar with most.
Yeah, I mean, your best bet for sure is to connect with someone at your institution or nearby who does the most. My email's right there. I would love to talk to anybody about the projects that they're starting. I am available and excited to work with people in a variety of areas on their most or optimization projects. The two books that we saw before from Dr. Collins are definitely, like I said, kind of the Bibles that you're going to want to read as well as if you are trying to combine it with implementation science, those two articles are really, really helpful. There's a Coursera course on most that is really fantastic. And then CADIO, which is at NYU, which is the center that Dr. Collins runs. They do online trainings, and I think that applications might be open now for one of them. Um, so those are an incredible resource. I personally attended like it was like an NIH funded like most course that Dr. Collins ran, and that was like the start of my education in this area, and I found it really helpful. The one other thing I'll highlight is that there is going to be an intervention optimization conference in Bethesda, I think in May. They're projecting that registration will be very limited. It's got a hard cap. And registration is either open or it's opening in the next like week or so. So definitely look that up if that's something you might want to attend. There's going to be tons of talks and resources there for learning more about this. That would be a great experience.
Thank you so much. That's great information. Okay, well, thank you so much, Dr. Goldstein, for your presentation again, and thank you everyone for joining us today. And just as a reminder, next Tuesday we'll have our next seminar at 12 p.m. We will have Dr. Linda Guzman presenting on bridging research and reality, partnering with communities to improve care delivery. So we hope y'all can join us again next week. Take care.
Thank you so much for having me.